Amy, just so you know, you're muted.
There we go. Can
Perfect.
everybody hear me?
Yes.
Thank you. All right, we'll go ahead and restart again. Good evening and welcome to the final Keeping an Eye on Innovation lecture for 2020. My name is Amy Loebner and I am the development manager along with my colleague Vanessa Peterson at the Retina Foundation. It is so wonderful to see many familiar faces tonight and to see those of you who are joining our lecture series for the first time. The mission of the Retina Foundation of the Southwest is to prevent vision loss and restore sight through innovative research and treatment. We see over 2,300 individuals, including infants, children, and adults, each year completely free of charge to help them learn more about their eye condition and to help further our research within the Foundation's 3 core research areas: pediatric eye disorders, inherited eye diseases, and age-related macular degeneration. This lecture series was created in 2018 to educate the public on the most up-to-date research from renowned leaders in the fields in our 3 core research areas. Lastly, I would like to take this time to thank Dr. and Mrs. William Hutton, our wonderful and gracious sponsors who are providing the support for this year's lecture series. I will now turn the evening over to Dr. Carl Jacque, Chief Executive and Medical Officer of the Retina Foundation, to introduce Dr. Jacque Duncan. Dr. Jacque?
Yes. Well, thank you so much, Amy. And it's really just such a tremendous pleasure for me to be able to introduce Dr. Jacque Duncan. She's a good friend and, you know, is really a true translational clinician scientist at the University of California in San Francisco, where she's the director of the Retinal Degenerations Clinic and the ERG lab as well. And I'm really excited because tonight, you know, she's going to be talking about adaptive optics. And the one thing about Jacque that just, you know, she has taught our field so much is because she's able, as you'll see, to take this very complicated technology and use it, and is teaching us so much about patients and the anatomy of their retina. And I know the field is completely appreciative of Jacque's efforts in this regard. And so it's literally with great pleasure that I thank Jacque for taking the time to speak with us, and welcome.
Oh, thank you. It is such a gigantic pleasure to be here with good friends, including Carl and David Birch. It's really an honor. So I wish I could be there in person, but thanks to COVID, we'll have to do it remotely. And thank you for your interest in the kind of work we've been doing, using some special ways of looking at the retina. And now I think I will, without further delay, share my screen so you can see my slides. And how does that look? Is that okay? Okay, perfect. Okay, so this talk is about seeing is believing, and this is meant to show you some new ways that we can see the retina, but even though we can see the retina, it's not as meaningful to be able to just see the retina as if the retinal cells we can visualize are able to see. So we're going to talk a lot, it's kind of play on words with seeing is believing. And all the work that I'm going to describe today has been done in collaboration with 2 wonderful colleagues, Austin Rorta at UC Berkeley and Joe Carroll at the Medical College of Wisconsin. So you may already know that vision cells come in 2 flavors. There's the nighttime vision cells, which are called rods. Rods work really well in dim light, and they're good for getting us around in the dark. And they also help us see off to the sides. But they kind of get overwhelmed when there's too much light around. And when that happens in bright light, we use a different kind of vision cell called cones. Cones, on the other hand, work not very well when it's dark, but they work really well when there's a lot of light. They let us see fine detail vision, and they help us see colors. They help us with our central vision. When the cones don't work, people can't see, and you have a hard time seeing in the center if you have trouble with your cones. But This is challenging for people who take care of patients with vision problems, because when, as a doctor, I look in the eye of somebody, I can't see their cones. No matter how hard I squint or how hard I try, the cones are too small and, just for a number of reasons I'll explain to you, hard to see. So we can look to astronomy, which is, as a field, has developed some strategies that are helpful in overcoming this challenge. So now we're going to switch gears and talk about astronomy. And it's when astronomers try to look at stars with a telescope based on the ground, they can look at a star that, and it would, with the normal telescope on the ground, look kind of like a fuzz ball. There's sort of a fuzzy blob there. And in fact, this looks like a big blob as well. But what it's really taken an image of is much more precise. We actually can realize, if we were looking at the real thing, this is not one blob, but actually two little stars right together. And it'd be hard to know that that blob came from two distinct stars. In addition, this is what this blob was. It's actually a picture of Neptune, and you would not know with just standard telescopes, because when we use a telescope based on the ground, there is a lot of turbulence in the atmosphere. So even though the air is clear and we can see stars, we can't see them with fine detail because of irregularities in the atmosphere or turbulence in the atmosphere. Well, a strategy to get around this challenge is a technology called adaptive optics. So the way adaptive optics works, and this is how it's used in astronomy, is they take a laser and they create a fake star. It's called a laser guide star, that they know where it is and how big it is and how it ought to look. And then they image it with a telescope. And in addition to looking at the star, they measure how much the air is turbulent, or how much the air is being distorted or deformed by the atmosphere. And in addition to measuring that distortion with a wavefront sensor, that information is communicated to a special mirror. And this special mirror can bend its shape. When it bends its shape, it compensates for these irregularities in the atmosphere and provides a very sharp image of the star in addition to other stars in the sky. So this is how it works in astronomy, to let us see very precise details of the night sky that are not visible with standard telescopes due to distortions in the atmosphere. We can take that same approach to looking at the retina. The same adaptive optics technology can be used to correct irregularities in light exiting the eye or entering the eye that prevents us from seeing small details with great precision. If we make the pupil bigger so that we can get a better picture of the retina, what happens is the subtle irregularities in the cornea and lens introduce kind of like the turbulence in the atmosphere, aberrations. And as the pupil gets bigger, this little dot of light turns into this weird distorted blur, and it prevents us from seeing fine details. Well, if we use that same approach with adaptive optics to measure the irregularity of light getting out of the eye, the aberrations, and communicate that information with a special mirror that can bend its shape to compensate for the aberrations, the light exits the surface of the mirror in parallel planes, and that provides us with a high resolution image that we can take pictures of with a special digital camera. So the effect of adding adaptive optics is shown here. Here now we have a little point source of light, and as the pupil gets bigger, it gets more and more well-defined. So to summarize, the technology of adaptive optics overcomes blur in images of the retina that's created by subtle irregularities in even the healthiest corneas and lenses of every eye, using a special wavefront sensor communicating with a special bendable mirror to give us very high resolution pictures of the retina. This is my colleague, Austin Rorta, who invented this kind of approach for use in the eye. And this is the machine we use to look at eyes of living people non-invasively. This doesn't hurt, doesn't harm the eye in any way, and allows us to look at individual vision cells in patients and people. The patient sits kind of right here. We use special lenses just like you might use for your glasses. And the special mirror that bends its shape is in this little area right here. So if I, as a doctor, take a look in a patient's eye, it looks a lot like this. This is a fundus photo that shows the optic nerve and some blood vessels. And this very center of the retina is the fovea, where people only have cones, the cells that allow us to see fine details and color vision. However, no matter how hard I squint or try to focus in on this, I cannot see the individual vision cells because of those aberrations that I just described. So what we'd like to do is apply adaptive optics to see the vision cells. And I'll show you first, if we use a special ophthalmoscope to see the retina, again, it's kind of dim and grainy and you can't really see any details. But when we turn on adaptive optics to measure the aberrations and correct for them, we begin to see little tiny dots. And each of those little white dots is light being wave guided or focused by a single cone vision cell. So this is a special approach that lets us see the individual vision cells that allow the patient or the person I'm looking at to see the world. With high resolution, we can now see every single cone in the mosaic of this normal person. This is another picture of a confocal image of the cones, which represent cones that have intact components, intact inner parts and outer parts, and that they're in contact with the underlying retinal pigment epithelial cells. We can use that same technology, and instead of collecting the confocal light that comes through a single plane of focus, we can collect all the light that doesn't come through that plane, which is the non-confocal light, to see other parts of the cell or to see cells that are not perfectly intact. So this is called split detector imaging. And you can see each of the cones in the confocal image, like I showed you on the previous slide, can be better seen with a lot of clarity compared to the neighboring image with a split detector image. So taken together, these two modalities give us a lot of information about the health of the vision cells in living eyes. We can use this picture in combination with a side view of the retina. This is a special image that we collect using a special machine called Spectral Domain OCT. This gives us the same kind of a picture, only looking at it from the side. And the same structures that we saw on the previous slide are seen as different alternating dark and light bands on this picture. So this dark band is where the cell bodies of the cones live. This little faint band is a little separator between the cell bodies and the inner segment of the cell. This really bright band is the connection between the inner and the outer segments of the cones and rods. And then this bright band is where the outer segments interact with the cells underneath them, called the RPE cells. So if we focus our attention on these outer retinal bands, we can compare them to the images I showed you on the previous slide. And we can see that these inner parts here, this dark part is responsible for this split detector image. And then this bright part here, where the cells are in contact with the underlying tissues and are intact, provide us with images on the confocal AOSLO scan. So taken all together, we can get a lot of information about the vision cells without hurting the patient in any way. We can also use a similar OCT scan to look at the blood vessels that supply the retina in the eye. We can use this optical coherence tomography scan, or OCT angiography, to look at blood supplying the inner retina and also this blood supply to the photoreceptors themselves. And this layer here is called the Choriocapillaris. And this is where the blood gets to the vision cells that we've been talking about this whole time. Okay, so I'm going to start talking about how we can use these special tools to better understand a very common cause of vision loss in patients in the United States called age-related macular degeneration. This is the leading cause of severe irreversible central vision loss among elderly people in the US. It accounts for more than half of the irreversible blindness in the United States. And as people are living longer, it is affecting greater and greater numbers of people. This picture of my husband actually shows that in general, you can see centrally and all around, but if you were affected with age-related macular degeneration and you wanted to look at the face of this person, if you had macular degeneration, the central vision would be affected. And this shows sort of a simulation of what it might look like to have age-related macular degeneration to indicate that the central vision is the part most severely affected in AMD. So when people have vision loss due to AMD, there's usually two reasons for that. Either the cells disappear and go away due to geographic atrophy, or new blood vessels grow under the retina. We have treatments for the new blood vessels that grow, which can be administered in the eye clinic, but we don't have effective treatments due to the atrophic form. So we typically follow people using special imaging of the underlying cells called the RPE cells with a kind of picture called the fundus autofluorescence. But we also use OCT like I showed you in the previous slide. However, these different images that we get don't give us a lot of information about which kinds of cells are dying first or are responsible for the vision loss. Whether the problem is really that the cells are going away, or are they going away because the underlying blood supply is not sufficient to keep them alive? It's some histological studies of people's eyes after they passed away, looked at under microscope, show that the blood vessel loss is sometimes more extensive than loss of the tissues, making us wonder if the problem is really that the blood supply is not sufficient to keep the tissues alive and working properly. So our goal was to study these tissues in living eyes of patients to better understand which tissues are affected more severely and earliest so that we can try and develop treatments that would target the primary problem more effectively. So we asked whether loss of the blood supply to the retina, Choriocapillaris, was associated with loss of the vision cells, the cones. And we used these tools that I described to you in the previous slides to look at the vision cells and the underlying blood supply. We focused on areas right next to the areas of atrophy, with the understanding that the area of atrophy is likely to expand as we look over time. And we asked whether the more severe problem was the blood vessels or the vision cells themselves. We studied a total of 8 eyes from 6 patients who have age-related macular degeneration. All of them had good central vision, but had vision loss around the center. And we compared this to 4 eyes of age-similar normal subjects. When we compared the images that using high-resolution technology, we compared them with kind of standard modalities as well. We take a color fundus photograph shown here where you can see this big area of atrophy right next to the very center. And we can use fundus autofluorescence to better delineate the area where the cells are gone. This dark area very nicely outlines the area of atrophy. We can then compare that with OCT scans, the side view pictures, to show the areas where the outer retinal layers remain right next to areas where they've been lost. And then we can look at the blood supply in this region to see how it's affected by the progressing areas of vision loss. So these are some pictures of the blood vessels underneath the retina and the retinal blood vessels. And we outlined the areas of atrophy and measured in 1 degree steps away from the edge how well the blood was perfusing the retina. What we've shown here is a little colorful pixel. If we fill in a pixel, that indicates that there's not enough blood flow in that region. So if we see blood flow, we don't put a pixel there. But if there's absence or slow flow, it earns a colored in pixel. We can see that we ignored the areas with atrophy and drusen, and we compensated for overlying blood vessels. And we could average the little areas of non-perfusion in these regions extending in 1 degree increments away from the edge to get an idea how the perfusion correlated with the edge of the atrophy, indicating which area might be expanding most and next. So what we found was in a normal age-similar normal eye that the amount of pixels where there wasn't flow was pretty uniform across every area we looked at, about 12%, between 5 and 10%. 5 and 15%. We looked at patients with macular degeneration, we saw something quite different. Instead of being kind of uniform at about 10%, which is what we saw in the areas far away from the edge, up close to the edge, we see really high densities of pixels indicating loss of blood flow in that area. We found that patients with age-related macular degeneration had worse flow than the age-similar normal eyes overall, and that the flow was much worse as we got towards the edge of the geographic atrophy and the areas of vision loss compared to the rest of the macular area that we imaged. So this all suggested that the blood supply around the edges of atrophy was compromised or was not as good as it should be, not as good as it was elsewhere in the retina. Well, then we decided to ask, we appreciate that the atrophy is associated with loss of blood supply, but how does this affect the vision cells themselves? And that's what we care about, because the vision cells are what we need to see. So we use the special imaging technology, adaptive optic scanning laser ophthalmoscopy, to image the individual vision cells. Like I showed you in the initial slides, we see little white dots, and each of them is a cone. This is from an age-similar normal eye, and I've used little green dots here to indicate where the cones are located in this normal eye. In similar locations, we looked at a patient where we measured the cones at the edge of the atrophy. This area down below has no remaining retina, and out here we see better preserved retina. And if we look at the cones in this area next to the atrophy, we see the cones are a little bit less well preserved, but not that different from normal. However, there are a lot more pixels of lost blood supply, up to eight times more than we would expect compared to a normal subject. So the blood supply was severely compromised, even though the cones were relatively well preserved. This slide summarizes the different eyes, the 8 different eyes that we studied. And here we're seeing how far apart the cones are from their nearest neighbor compared to the location away from the very center. And this shows you what a normal distribution should be. So these little gray dots are normal, and the blue and purple and red are from our patients and from our normal subjects. The red symbols show you areas where the blood supply to the retina was reduced. So here, even though the blood supply was lower than normal, the cones looked really well preserved in the normal eyes. If we look at the patients, we see again that most of the cone spacing was within normal limits, indicating that they hadn't lost a lot of their cones. But these red areas indicate that the blood supply beneath the retina was very abnormal, even though the cones were still remaining. And if we focus on all the different subjects that we studied, this is all the normals we studied in addition to each of the individual patients shown on a separate graph, we found that the distance between the cones, or the number of cones remaining, was correlated well with the amount of loss of blood supply. The areas with worse cones, less cones remaining, had less blood supply. We also found that most of them actually had pretty well preserved cones, but there was evidence of cone loss about 40% of the time. However, the Choriocapillaris perfusion was reduced 96% of the time. So it indicates that Choriocapillaris perfusion, the blood supply to the retina, was more abnormal than you would think based on the number of missing cones or surviving cones. Cones were relatively well preserved, even in the presence of lost Choriocapillaris. Well, now we wanted to know, how does this predict whether the geographic atrophy is going to get worse over time? And here we've shown a study of 12 eyes of 7 patients that we followed over time between 7 and 16 months. We found that there was a strong correlation between the likelihood that an area had lower than normal flow at the beginning of the study and the likelihood that that area was going to get worse over time, suggesting that the rate of expansion was significantly correlated with the underlying blood supply. And regions with lost blood supply at the beginning of the study were about 33% more likely to develop progressive loss of vision over time during the study. Well, finally, the most important question might be, how does this correspond to vision? Because the vision cells are really most important because in that they allow us to see well, and when we see expansion of the atrophy, that's associated with vision loss. So we used a special approach called microperimetry, where we measured vision in the macula at a number of different locations of 20 eyes of 13 people who had macular degeneration with atrophy. And these patients were all between 70 and 90 years of age. We used the OCT to look at the blood supply of the underlying retina, and we excluded areas where there was atrophy and also other problems like drusen and blood vessels that might create artifacts. And then we compared those areas with measures of vision. And this is an example of the way the measures of vision look. So the dark areas here indicate areas that weren't seen by the person, whereas the brighter colors are areas that are closer to normal vision. Green would be normal, red is not very normal, and black is not seen at all. So this slide summarizes 20 eyes from 13 patients that we looked at with geographic atrophy due to AMD. This slide shows that we saw a significant correlation between the ability to see the flash, retinal sensitivity was greater in areas with the least loss of perfusion. So the areas with the best blood supply had the best vision. On the other hand, the areas with the worst blood supply tended to have worse vision. I've colored these green compared to red to indicate the distance from the edge of the atrophy. So the green areas are more than 5 degrees away from the edge of atrophy, whereas the red areas are right up against the edge. So again, you can see the areas closest to the atrophy have the worst vision and the worst perfusion, whereas the areas far away from the edge of atrophy, where the atrophy hasn't gone yet, have the best vision and the best perfused blood supply. We also studied flow void or perfusion and compared it to distance from the edge of the atrophy. And similar to the previous slide, we found a significant correlation. The areas that were very close to the edge of the atrophy had the worst perfusion, worst blood supply, whereas the areas farthest away had better perfusion. And we also compared sensitivity to distance from the edge. So here we see that right up against the edge of the atrophy, the person's not able to see, the areas were not, the lights were not well seen. You had to have a very bright light to see it at all. Whereas far away from the edge, the vision was much, much better. So we determined from all of these, we concluded from our findings that this was somewhat similar to histological studies that have been done on eyes after the person has passed away, which have shown there is loss of blood vessels in areas even where the overlying retina looks pretty well preserved. Our study showed abnormal blood supply in areas where the cones were pretty well seen and pretty close to each other in a way that they should be, not different from normal. We also found that the blood supply correlated well with the ability to see. The flow correlated with the ability to perceive the lights, and areas that had the worst blood supply were the most likely to show expansion and get worse over the time that we followed the patients. So to finish my section of the talk on macular degeneration, we found that patients who have age-related macular degeneration and geographic atrophy, or vision loss due to the cells going away, showed the worst blood supply, or increased flow void, at the edge of the atrophy. We found that reduced blood supply corresponded to cone loss over time, and that the loss of blood supply predicted areas that were likely to get worse over time. We also found that reduced blood supply was corresponded to worse vision. So combining all these different high-resolution imaging technologies gives us the idea that the vision loss in patients with macular degeneration may originate in loss of the blood supply with secondary loss of the overlying tissues. I'm going to switch gears and spend time now talking about a different kind of retinal degeneration. Age-related macular degeneration is also retinal degeneration. All retinal degeneration share in common loss of vision due to photoreceptor death. We don't have very effective treatments or certainly cures for patients who have retinal degenerations that run in families or inherited retinal degenerations for most patients. And most of them experience slowly progressive loss of vision over many, many years. In this type of vision problem, instead of the macular degeneration one, which affects the central vision very early, in this type of disease, which often affects nighttime vision cells earliest, the rod cells, the central vision is often well preserved until late stages of disease. And here, this is a form of retinal degeneration called retinitis pigmentosa. And this is one that doesn't affect the central vision early, but instead affects the nighttime vision or the rods. So the night vision is affected early, but the central vision is well preserved until late in the stage of disease. And unlike the picture I showed you a few minutes ago, again, we see the optic nerve, but the blood vessels are thin, and we see pigment changes, some areas where there's dark pigment in areas that the photoreceptors have been lost. The best, most normal part of this picture is right in the center, where the best vision remains. If we look at the same picture from the side, again, using OCT to provide a side view, and we look for those outer retinal layers that I talked about earlier, we can see that right in the center, we see all those bands that we talked about before, the cell bodies, the inner and outer segments. But if we get not very far away from the center, we lose the outer retinal layers, and we see areas where the photoreceptor cells are not present anymore. You can't see them in side view. So the retinal structure gives us a lot of information about the retina and tells us which areas still have cells remaining, but we really care a lot about how well those cells can perceive stimuli, perceive light, and look at things. So again, the imaging photoreceptor structure is valuable, but the structure is mostly valuable to patients if it predicts visual function or the ability to see or read letters on an eye chart. Both patients and regulatory agencies like the Food and Drug Administration care a lot about how those images we take correspond to the patient's ability to see things. So it's very important not only to take very high resolution pictures of the retina, but also to understand how well those cells can see. Well, it turns out we can use that same adaptive optics approach, not only to see the vision cells themselves, but also to deliver little spots of light to individual groups of vision cells. And the way we do that is we sort of use the same focusing technique to eliminate irregularities in the light and aberrations, and to precisely focus the light on small regions of the retina. So if we look, the patient who's being imaged sees a little green flash and is asked to push a button when they see that flash on a red background. And when we're taking pictures, we can see the individual vision cells, like we showed before, little white dots, being exposed to little red spots of light. And when we see, then we can be sure exactly which part of the retina is being used to allow this person to see the flash of light. So we use this approach to better understand how measures of cone structure with adaptive optics correspond to measures of visual function. And this is work done by a former graduate student in Dr. Ostnervorda's lab at UC Berkeley. And we chose to use this approach to try and better understand how vision is affected in patients with retinitis pigmentosa caused by two different genetic mechanisms. One of the most common causes of retinitis pigmentosa is due to mutations in a gene called rhodopsin, or RHO for short. This is a gene that is exclusively expressed in the nighttime vision cells, or the rods, which explains why the first thing that patients with rhodopsin mutations experience is trouble with vision at night. Then they start to lose vision off to the side, and eventually the central vision is also affected. Because this is a rod-specific mutation, it tends to spare the cones until later in the disease. We also compared this type of retinitis pigmentosa with a very common cause of X-linked retinitis pigmentosa, which tends to affect men more severely than women, associated with a gene called RPGR. Now, this gene, unlike rhodopsin, is not only in the rods, but is also expressed in the cones. It tends to affect the rods first and earliest, but eventually causes central vision loss as well at an earlier stage than patients with rhodopsin mutations. We wanted to better understand how the different types of retinitis pigmentosa cause or affect the vision cells in patients with rhodopsin mutations. Again, that is exclusively expressed in the nighttime vision cells or the rods, compared to the RPGR mediated forms of retinitis pigmentosa, which is expressed in the rods and the cones. Here I'm showing rods only, and RPGR is in rods and cones, and expressed at a particular part of the cell called the connecting cilium, which is responsible for that inner segment, outer segment junction band that we can see on OCT. We enrolled 4 normal subjects and 4 patients with autosomal dominant retinitis pigmentosa due to rhodopsin mutations. Again, that's the one that's only in the rods. We compared this to 5 patients who had mutations in a gene called RPGR in the rods and the cones. And we looked at the vision cells with adaptive optics, and also expose the vision cells to very small spots of light so we can better understand how well those different vision cells could see. This slide shows an example of a normal subject on top, the rhodopsin rod-mediated cell form of retinitis pigmentosa in the middle, and the RPGR form of retinitis pigmentosa at the bottom. In all of these subjects, the central vision was excellent, shown here with a green dot, and the patient was able to see the little spot of light as well as normal people at the central area. But as we start to get away from the center, we begin to see colors that are a little more yellow and then all the way to red, indicating less ability to see the flash of light, requiring a brighter flash. Let's take a look at the cones in those areas where the vision is not as good as it was in the normal subject, which is green at every location we look at. So here's an example of that sort of intermediate spot, which is yellow, not green, not red, but just a little bit reduced in both the patient with a rhodopsin mutation, shown here on the left, and a patient with an RPGR mutation expressed in the rods and the cones, here on the right. We can say that at a place where almost the same number of cones remain, the vision was worse in the patient with the RPGR mutation. And you might expect that to be true because when we looked at this in all the patients and averaged the results, we observed that the cones from the patients with RPGR mutations, again, this is the mutation that is expressed in the cones, was worse than the people who had rhodopsin-mediated retinitis pigmentosa, which again, rhodopsin is not in the cones. So the rhodopsin cones were pretty close to normal in their sensitivity on a cone-by-cone basis. But the RPGR mutations not only showed worse sensitivity per cone, they also showed shorter outer segments per cone than both the rhodopsin and the normal subjects. And it indicated that the outer segment length and the sensitivity was lower in the RPGR-mediated cones. And perhaps because the RPGR mutation is expressed directly in the cones as well as the rods, whereas the rhodopsin mutations are only in the rods with secondary impact on cone survival. So this indicates that the RPGR-related RP shows a disconnect between the structure and function that isn't evident in the rhodopsin patients, and might be the kind of thing that if you were able to treat the RPGR patient with maybe gene replacement, you might expect that you might be more likely to improve vision in the patient with the RPGR form of RP than the patient with rhodopsin-mediated RP, because in the rhodopsin-mediated RP, the loss of sensitivity corresponded to the loss of structure, whereas in the RPGR-mediated one, even with the same amount of structure, the function was worse. I'm going to finish by talking about an inflammatory form of retinal disease called acute bilateral foveolitis, this was an example of a young woman who was entirely healthy until she developed an upper respiratory infection. And when she came to the clinic, her vision in the right eye, again, this is now affecting the very central vision only, vision in the right eye was reduced from normal of 20/20 to 20/80. So very reduced to seeing only big letters on the chart. And the left eye also was reduced almost to 2200, which would be legal blindness. What was interesting was she returned to our clinic for follow-up 5 years later, and the vision in the right eye had gotten much, much better to 20/25, almost perfect. If we magnify the fundus image, again, I can't see individual cones no matter how hard I squint or how much I magnify this, but what's different in this patient is we see a very well-demarcated round area at the center that doesn't look quite right. Instead of being kind of the same color as everything else, there's a little area that's more yellow than it ought to be. So we decided to take a careful look at this area to try and understand why the vision got so much better, even though it looks like there's a very discrete area of abnormality. We look at the retina inside view using an OCT, and we see this little gap in the area where the vision cells ought to be. And I'll magnify that here for you and show you that if we look at this vision cell band that goes along with the inner segment, outer segment junction band, we see that it looks pretty normal until you get to this spot right here where there's a gap. And that corresponds to this area, this well-demarcated circle that we can see on the fundus exam as well as the adaptive optics image. We also see this other little band, the external limiting membrane band, is extra thick and extra bright. maybe indicating that the cells, parts of the cells that used to be down here got crumpled up into this little area. And more importantly, indicating that there's no real loss of tissue here. It may just be kind of contracted up in an area that we can't see when we look at it the way we normally check. So we decided to better understand why this patient was able to see as well as she could at almost normal at 20/25, despite having this very clearly demarcated area. And the little white spots are the areas that this patient used to look at these flashes of light. And it's very surprising that she can actually use this area that looks like it has no cones in it to look at flashes of light. So with these adaptive optics images that I just told you, show us where the cones are, and it looks as though there are no cones there in that area that she's using to see these tiny little spots. Why would she continue to use this area that looks like it has no cones to look at little targets? Well, it's because probably there are cones there, although they're not quite normal. So we decided to use to change the adaptive optics machine to use it itself to show a letter E to the patient and know exactly which part of the retina she was using to visualize that flash of light. And here you can see the image of the letter E, and every time the patient looks at it, it's right in the area where it looks like she has no cones. We also asked her to push a button when she saw a light, and we saw that although it's not quite as good as the area around the edge, she could still see pretty well. She could see a little bit brighter flashes of light than was necessary. And so then we had her look at the letter E and tell us which direction the E was pointing. And she really always put it right smack in the middle of that area that looked like it was missing the cones. So when we presented this tumbling E to her, she looked at it with the area that looked like it had no cones, and she got the right answer almost half the time. The chance of her getting the right answer almost 50% of the time, occurring by chance alone, is less than 0.13%, indicating this was a statistically significant difference or improved ability to see than what we would expect from just random error, and that she was just placing it there by mistake. So we decided to call these cones that look like they're absent but still are able to see dysflective, because they aren't reflecting light the way the rest of the cones do. We call a dysflective cone whenever we see a pattern that looks like this bright, very extra bright and thick area called the external limiting membrane, which is up above a gap in the area where the cone bands usually live. And patients tend to still have meaningful function in that area. When we see parts of the image that don't have visible cones, but still can see, we assume that they still have inner segments, but maybe missing the outer part of the vision cell that is necessary for vision. Other people have seen similar kinds of changes on adaptive optics imaging, not indicating that this is not specific to this patient's infection, but this is a more generalized thing that happens after trauma, for example, which this is a patient who had been hit in the eye with a ball. You can see there's areas where the vision cells appear to still be present on the split detector image, but appear to be absent on the confocal system. And similar appearance on the OCT where there's this gap in that outer retinal band. These cells are important to know about because they might be able to see even though they look like they're not there. More importantly, they might be the most likely cells to recover in response to a treatment or to get better on their own over time, as was the case in the patient I showed you. So it's likely that retinal degenerations progress slowly over time, and it's important for us to be able to identify remnant evidence of cones because the way photoreceptors die in retinal degenerations is that the outer segments go first, and then the inner segments are affected, and finally the cell bodies of the cell are affected last. So if you lose the outer segments, the vision declines. But it doesn't mean that that cell is irreparably lost. There certainly might be remaining cell structure that could respond to treatments and get better over time. So we think using special imaging modalities like OCT and adaptive optics allows us to image cells of the retina that might be most amenable to different kinds of therapy and demonstrate cells that have the potential to respond to treatment. So I hope I've convinced you that seeing is believing. We can use high-resolution new tools to study individual photoreceptor cell structure and function in living eyes non-invasively. This may provide us with insights into how different types of genetic mutations cause photoreceptors not to see as well and to go away over time, not survive. And we think this might provide us with a sensitive way to study disease during the course of degeneration and ideally during response to therapies in people with retinal diseases. These are the many, many people who have helped contribute to this project, as well as the numerous sources of funding that made the work possible. Now, I'm happy to answer any questions you may have.
Well, great. If we could clap, that would be a group clap, because that was a phenomenal lecture. So thank you so very much.
Thank you.
So as Amy has maybe sent out, if there are questions, it's, with this many people, it's hard to kind of see who's raising their hand. So hopefully, please, if you have a question, try to put it on the chat box. That's going to be the most effective way for us to get these questions answered. So Jacque, we've got some, as your lecture was really inspiring, and people now have some very good questions for you. And
thank you. That's great. I will do my best to answer them.
So this was from Ronnie Park, who has a question about recessive Best disease.
Okay.
And what exactly, the question is, if a subject has an increase of the fluid or the rupture of the blood vessel, and we know the rupture of these Best disease, kind of material. Have you all looked, or what are your thoughts about the progression, or in this kind of disease, where does adaptive octos perhaps play a role in our understanding of Best disease?
That is a really interesting question. I have to admit, I have not yet had the opportunity to image anyone with the autosomal recessive form of Best disease. I have imaged a number of people with the autosomal dominant form, which is different, and I appreciate that. But it can speak to the features of autosomal dominant Best trophinopathy in hopes that that might be interesting as well. In that disease, in some ways, it's a little bit like age-related macular degeneration in that a yellow fatty containing kind of substance accumulates under the central retina where the cones are. And we see in early stages of disease, the cones line up very nicely over the top of that lesion. And oftentimes those cones can see very well. Patients have really good vision, can see the cones very well preserved and looking almost normal for a long time. Eventually, that fatty material begins to affect the overlying vision cells and starts to cause the RPE cells to break down. And at that point, sometimes fluid gets under the retina. And when that happens, we don't see the cones as clearly. Sometimes they appear more like those dyselective ones I showed you at the end, because their outer segments are not in contact with the RPE cells anymore. That's when the vision starts to decline. So we think this kind of imaging approach can give us insight into all kinds of different diseases, including autosomal recessive Best trophinopathy.
Fantastic. We also have a question from Lynette, who actually has a very intriguing question. Wanted to know if this has given us some insight into cystoid macular edema associated with RP. And
what a good question. I have to say, so that is a really challenging problem that is, when I mentioned before that retinitis pigmentosa tends to affect the night vision and the side vision, but the central vision is well preserved, unless someone develops macular edema. The macular edema can really compromise central vision. And honestly, we don't have the best understanding of why macular edema occurs. Some people think that it's because the underlying RPE cells aren't pumping the fluid out like they ought to. And sometimes we use different treatments to try and enhance the ability of those cells to pump out the fluid. We have studied some eyes with macular edema. It's a little tricky because the fluid creates a little bit of a lensing effect and makes it a little bit of an artifact of our ability to see what's happening to the cells, because it's kind of compromised our ability to study the underlying cells. But I think we are beginning to investigate a layer that I didn't talk about very much today, which is the RPE cells. The retinal pigment epithelial cells are super important for normal vision and also for maintaining the normal fluid status, including macular edema of the retina. We're using that OCT angiography image and OCT side views of the retina to better look at that RPE layer. And I'm predict that, in fact, the RPE abnormalities probably contribute a lot to that macular edema. And maybe with that type of approach, we may get a better idea like why it happens, in whom it happens, and maybe how it's responding to different therapies.
Fantastic. Diane Buddy just wanted to say thank you. She thought, that you really were able to explain. As I said, this is a complicated, area, and you did a phenomenal job. She just wanted to say thank you. Richard Shar, asked a question that's near and dear to my heart, and that is, the idea that blood flow into the choroid may be a major role in AMD. And do you see any differences? I mean, he's asking, is there ways to control that?
Yeah.
Do you see any, anything in terms of from patient to patient? Are there any significant differences suggesting that some patients, as you showed, have more flow, less flow? Mm-hmm. Is there anything in their medicines or anything that you think might give us some insight into how we might be able to control the blood flow that you so elegantly showed?
Thank you for that. That is a very important question. And I work closely with one of my colleagues who I actually didn't put on the slide, and I apologize for that. Dan Schwartz at UCSF is very interested in just that question. And he has some very innovative ideas about ways to improve the blood supply to the underlying choroid with different kinds of pharmacologic interventions that he thinks might be helpful in just that way, helping to get the blood, to improve the blood perfusion of the underlying cells, to try and keep the cells alive longer. So he's trying to get more research support to try and identify and develop new treatments that would do just that, try and enhance the amount of blood coming to the outer retina. Honestly, we haven't studied enough patients to say what makes one patient more likely to have that than another. It's probably related to systemic risk factors like hypertension, hypercholesterolemia, different kinds of things, but I have not looked at enough patients to know for sure which of those risk factors are the most important.
Great. And Rand Spencer, who's also one of our retina specialists here, wanted to know, and it's something that I was also going to kind of ask you as well, and that is this relationship he's asking between the photoreceptors in macular degeneration as a primary problem within secondary loss of the vascular structures, or what goes first. And in that regard, we always look at Stargardt's geographic atrophy as kind of a cousin of geographic atrophy and macular degeneration, even though there are two different diseases. Any insight into this relationship between photoreceptor loss, choriocapillaris loss, even in some of the retinal degenerations? Is there something else that's specific to macular degeneration that your work is teaching us?
Yeah, great question. So we have looked at, so our evidence that I showed in this talk, in a paper that was from a couple of years ago, indicated that the cones were pretty well preserved, even in areas where the choriocapillaris was not as well preserved as it should be. And this was more, sort of similar and comparable to what histological studies had shown, where the choriocapillaris looked more abnormal, even in areas with pretty well preserved RPE before the atrophy developed. So we think, and I don't know for sure whether dysfunction of the photoreceptors and RPE secondarily causes the choriocapillaris to disappear, but I can say that structurally, choriocapillaris abnormalities seems to extend beyond and be more severe than loss of the cells, the RPE cells and the photoreceptors in AMD. We're also beginning to look at myopic macular degeneration, patients with very nearsighted eyes, and finding similar kinds of things where there's loss of choriocapillaris perfusion, even in areas that appear to have pretty well preserved photoreceptors and RPE cells. So we think it probably does play an important role, at least in those diseases. I haven't looked a lot at Stargardt yet, although it's something that's certainly near and dear to my heart. I would like to look at more patients with that over time.
Fantastic. Well, again, I want to give Amy just a couple of minutes before we get to the end of the hour to say a few comments, but I want to again express my thanks, Jacque, to you for taking the time. That was a phenomenal lecture, and I'm so glad that you were able to make the time and teach us so much, as you always do, about this approach, and it's always a pleasure. So thank you so very much.
Oh, it was really an honor and a privilege. I wish I could be there in person to express my gratitude and meet every one of you, hopefully someday.
Absolutely. And so with that, I'll pass it over to Amy for final words.
Great. Again, we just thank all of you for joining us tonight. As usual, we will continue with our Zoom lectures for now, and we will release our 2021 lecture dates likely in early January. So stay tuned for those. You will all get an email. Additionally, other ways that you can become involved with the Retina Foundation if you are interested is to join our auxiliary. As a member, information is on our website, and we would welcome all of you as well to get involved that way. And lastly, please do, especially in this time of COVID and a lot of us working remotely, please do check our website frequently for updates about our research, as well as we are on social media, Instagram, Facebook, and Twitter. And we do post our latest and greatest research efforts and many other exciting news about our events. So I would welcome all of you to check there. And again, thank you so much for your support of the Retina Foundation and joining us this evening. Thank you again, Dr. Duncan, and as well as Dr. and Mrs. William Hutton for supporting our lectures. Take care.
Thanks, everybody.
Thank you all.
See you all.